The Virtual Curbside is a production of the Utah chapter of the American Academy of Pediatrics, the Utah AAP, working together to improve children's lives through education, advocacy, and networking. Hi, this is Paul Wirkus from the Utah AAP. Welcome to this week's edition of the Virtual Curbside, where we bring pediatric providers together with subspecialists to get smarter about all things pediatric and better acquainted as a community of caregivers. The Virtual Curbside is brought to you in part by a generous grant from Primary Children's Hospital. Primary Children's Hospital, the child first and always. Attention pediatric healthcare professionals. Are you ready to hear the latest insights on pediatric care? Sort of like you hear on the Virtual Curbside. Join us for the 47th Annual Common Problems in Pediatrics Conference happening June 3rd and 4th, 2025, all virtual. This premier event features expert speakers and cutting-edge topics, all from the comfort of your own home or office. Earn CME and MOC2, connect with colleagues, and elevate your practice. So don't wait. Register now at aaputah.org events. Welcome back to the Virtual Curbside. This is your host, Paul Wirkus. Thrilled this month to be able to have Dr. Stephanie Spanos with us, talking about office-based emergencies, which is a big deal. Welcome to the podcast, Stephanie.
Thank you.
This has been a labor of love for you for a while, hasn't it?
Oh, yes. This actually has been my career. It started pretty much shortly after I arrived here. I was in the emergency department and received a phone call from a pediatrician, and he had a patient who was coding, and he said, "I need help." And I said, "Well, what medications and equipment do you have?" And he said, "Nothing." And I said, "Okay, please start CPR and call 911. And we hung up the phone so he could do that. And then I just thought, wow, someone needs to do something about this. And that probably would be me, since I do simulation and emergency medicine. And so that's what launched it, was actually a call from a pediatrician having that emergency and not been able to be prepared. And so that's what I've been doing throughout my.
And doing brilliantly. Before we proceed too much, first of all, do you have any financial disclosures that you need to make?
No disclosures.
Okay, so you're not going to be selling any secret tonics as part of our conversation today?
No.
A little disappointed, to be honest. So you are in the emergency department at Primary Children's Hospital, Division of Emergency Medicine in the Department of Pediatrics there, working at both campuses, both Salt Lake campus and the Lehigh campus. Is that right?
Yes.
Yeah. And you're also the director of the fellowship.
Yes, I recently took over as program director for the fellowship, and I continue to do simulation for the hospital, all of the staff, and all of our outreach opportunities. So medical director for multiple simulation programs as well.
Now, much of the text of our sermon today comes from an article called Pediatric Office Emergency Preparedness and Intensive In-Office Training Curriculum from Pediatric Emergency Care about 2.5 years ago. Now, the author of this article, Stephanie Spanos, any relation?
Well acquainted.
Yeah, I mean, this is a fascinating article because the substance of the article, tell me if I'm misrepresenting this, is really an integration of what you've learned from helping people to do this. So it's an iterative process that you set out to get people better at dealing with emergencies. And this is now a list of recommendations that comes from your experience.
Oh, yes, it was fascinating. And I am so grateful to all of the staff that participated and had faith in me and trusted me to come in, and my simulation team. But we were able to go into multiple practices and run pediatric emergencies via simulation. And, for people who don't do simulation, it does take some, kind of bravery on their part. So I do appreciate them for doing that. And it was really just eye-opening for everyone. I think that people think they're prepared, and I had surveyed the offices ahead of time, and the physicians thought they had the medicines, the equipment. They thought that their staff was prepared. And really, that is the genius of simulation, is that it really tests us. What would we do in an emergency? How prepared are we? What happens when we panic? Because if I sit around a table with you and we just talk about what you would do, you usually come up with most of the right answers. And then all of a sudden, we put you in a simulation, and luckily, it's just a mannequin. So no harm, no foul. It's just a mannequin, but you really realize what you know, what you don't know, It's easy to say I would intubate or do an IV or do an IO, but when you need to get the equipment, actually do the procedure, you realize what you know or don't know. And it really also revealed the staff, office staff, and they didn't know what to do in emergency, although they wanted to be helpful. And so that was really a great experience to help all of these wonderful people who are there in the office who hadn't experienced an emergency, how to be helpful when that time comes.
Yeah, full disclosure, our practice had you in, and let me just say, I mean, you're a great teacher, and it was a good experience. I think you worry in that sort of setting that you're just going to be exposed for all your flaws. We definitely found flaws, but also I think we learned a lot in the process. So thanks for that. Now, I think that the main thing that most of us do to address emergencies is we just make sure that we have that thing on the phone tree at the first that says, if this is an emergency, dial 911. And that way we've got it covered. Is there anything else that we ought to do?
I think actually having conversations with parents about what that emergency is, I think everybody's used to getting that and ignoring it. And they think the pediatrician is their doctor. Their pediatrician is the go-to. And you will then decide if they need to go to the emergency room. And, the emergency room comes with a significant expense and time delay. And so there are some people who really want to avoid the ER, even though it really was the right place for them to go. And they will, however, instead go to the pediatrician and be like, well, I'm going to let my pediatrician decide.
Right. And one of the other things that you touched on before is that when you do these simulations, you do it with the actual office staff. And so it's not somebody sitting at the table saying, then we would have the front desk. Instead, the front desk is there and you say, so what are you going to do? And it becomes so apparent that everyone has a part in this and everyone needs to be prepared.
Oh, yes. That was just a beautiful experience, I think, for everybody, not just to be included, but recognize how important each person is in that office to an emergency. And yes, I started the simulations as a mother coming in with my baby or my child to the front desk. And I just said, hi, I had an appointment for later, but I was worried. I think he's worse. And so I came in. And it's just great to see how the front desk staff would respond. And some of them literally would say to me, I don't know what to do. And I think that's so fair because if they haven't been trained, they wouldn't know what to do. And so it was really great to just start the process from what happens when a parent comes in with their child, just from the get-go, not just training the doctors or their support staff that are back there normally doing patient care, but this really does start with your front desk staff, recognizing an emergency, alerting the office, what do you do with that patient? And then they can be really helpful during an emergency. And they did not know that. And the doctors didn't know that. So it was so great to reveal these things.
Well, I think the thing that is very clear from the way you do this is that I think in most instances, people want to do the right thing. And it's empowering to know what the right thing is. And then it's even more empowering to have practiced it before and also to have the infrastructure available to actually do it right.
Absolutely. I think that one thing I noticed was the staff didn't know they could be helpful or how to be helpful, and they weren't used to speaking up. And, that's a culture in the hospital we've been working on for 20 years is getting everyone to speak up. Unfortunately, for decades, you would never have interrupted the doctor, heaven forbid. And yet what we have found is that a lot of medical errors occurred because people weren't speaking up. Please interrupt me, tell me information. And it was so great to see that when the staff did not feel comfortable speaking up, that during the simulations, the doctors were turning to them and saying, oh, please, I do need you to speak up. Something as simple as calling 911. We all think, well, of course, that'd be the first thing all of us would do. There's an emergency. We're going to call 911. Duh. If we were around a table, that's one of the first things you would say. But the fascinating thing was that got forgotten over and over because the patient would come in, everyone would want to just jump into action doing things to take care of this patient, and they would forget that we needed to call 911. And so about 20 minutes into a simulation, the doctor would say, well, where is the ambulance? And I would say, you haven't called yet. And the despair in the room, right?
It's at the ambulance store. You haven't ordered one.
So we empowered the front desk to speak up, to interrupt the doctor and say, hey, doctor, do you want us to call 911? Because really they needed that prompt. And then we needed somebody to do that task. And it really, as you said, it's empowering for the front desk clerks to hear that they have a very important job, an appreciated job.
Another thing that I think it can be a bit of a challenge is that I think we come out of training, and I think that the older we get, the more we sort of rethink this. But I think we come out of training saying, I need to own this. And, I have seen this done before. I've participated in this before. I have been brilliant before. So I need to own this start to finish, where really my office really becomes a clearinghouse for I need to do everything I can to keep this person safe until this child can go to the right place for the ultimate treatment.
Oh, and I think that was something that was spectacular to recognize with these simulations because the doctors, I think, are used to do, like you said, we're trained and we think we can do it all. And the reality is there's no way you can do it all because you're the skeleton crew, you're the early morning, you're the evening clinic, you're the weekend. A lot of the offices are staffed with a doctor, a medical assistant, and like a front desk clerk. There's 3 of you there. And so all 3 have to know how to take care of this emergency and work together as a team. And, if you have an emergent patient, you're talking about airway, breathing, circulation, there's CPR. And what about getting medications and who's calling, who's doing, who's grabbing emergency supplies. And you cannot do that alone as the doctor. And during this time, you're also supposed to be thinking and
Right,
potentially
right.
doing math and calculating medications and who is getting the medications, who's drawing up medications. In the hospital, in the emergency department, I have a team. I have like 10 people around this patient who are all specialized to take care of this patient and resuscitate them. And so you take that exact same patient and put him in a pediatrician office. And so you're asking a doctor, medical assistant, and a front desk clerk to do the job of 10 specialists in the emergency department.
And even in the emergency department, there are going to be most of the patients who you're going to be able to provide treatment for and they can go home. But you're still also thinking in terms of appropriate triage. Is it home? Is it to the floor? Is it to an ICU? And it's not a sign of weakness in an office, I think, to say, I need to do everything I can to keep this person safe. But the triage point here is that if someone is having an emergency, this is not the right place to keep them.
Well, and when I teach all comers, so I teach, a variety of hospital teams, outside EDs, urgent cares, offices. And one of the first things that I say is you call for help. And now call for help means different things, right? So in a hospital, you maybe press the code blue button. In the ED, we're pressing a code button in a different way. In an office, it's calling 911, but in calling your staff, yelling for help, get help. Because whoever's there is going to need help. But really in an office setting, if you have the truly emergent child, you want to call 911 as soon as possible because then you're getting more teammates with more equipment, more medications, and then also they can get that child to more definitive care. But you still have a job to do for that 10 to 15 minutes before an ambulance gets there. If you're lucky enough to just have a 10 to 15 minute arrival time from an ambulance, you really have to think, what is the time for an ambulance to get to my office? And so if I had a patient who had a code, because that has happened, it's just picked the wrong place, wrong time for the wrong disease process. And, they can go down in your office. And so are you prepared to take care of that patient until an ambulance has arrived? And that's what this entire curriculum and that paper is about, is what do you need to be able to do to save that patient? And it comes down to preparation. I would just wish everyone could see, we would do 2 simulations. And the first simulation, everyone really understood how they didn't have meds, didn't have equipment, didn't know what to do or what their teammate could do. And some of it was thinking they had medicines and then realizing it was like a pre-arranged kit. And then 85% of it was adult and not pediatric, but no one had checked that.
Right.
Or they had stored the emergency equipment behind the holiday decor in a closet. And so you had to get all the holiday decor out of the way to get the emergency supplies. But, it really is about understanding, if a patient goes down in my office, how do I respond, call 911, and then I need to be able to take care of this child for 10 to 15 minutes because I have prepared, I have meds, equipment, I trained, and this patient is going to do well because I prepared.
Right. Let's talk about some of the potential emergencies. So you talked about doing simulations, going in with the child and, saying things are worse than they seem. So some things are bad when they arrive and some things become bad after they get there. Let's talk about a couple of categories. Respiratory distress. That's definitely something we see in offices.
Yes, I think respiratory distress, when you look at the literature and I survey the offices, respiratory distress is the most common. Certainly we have all heard many stories of the bronchiolitic who was in a car seat with a blanket over the car seat and nobody knew they were blue until somebody pulled back the blanket. And that's one of the advice that I give all the front desk clerks is you have to eyeball every patient. You cannot let a parent check in with a blanket over the car seat and not see that child. They are your responsibility when they enter the office, just like for us in the ED, they are our responsibility as soon as they enter the waiting room. And so that's the job of a triage nurse is look around the room and pull people out of the line that you're worried about first. And so training that front desk staff to look for those sick patients first. But yeah, certainly respiratory distress is the one that seems to be reported most often. I think after that, it's probably more like seizure and dehydration, and one of the worst kiddos I've taken care of actually was a child who was in the back seat. Mom pulled into the pediatrician office parking lot and it was gastroenteritis, very common. But
Right.
she looked in the rearview mirror and his lips were blue and she thought, ooh, I should probably just go to the ED. Then thankfully she did, but she pulled out of the pediatrician office parking lot, drove up to the ED, came in the ED and I took care of him and he coded. And
Yeah.
so gastro, we're so used to it, but it can go terribly wrong.
Right. Well, and there are other things that cause circulatory collapse. We see infections sometimes that are overwhelming and they don't necessarily choose the infections to happen in a way that makes parents know what to do. And
Right.
so we were talking beforehand a little bit. Your pediatrician is your pediatrician. And so despite what the phone message says, it's hard to process all that. And it's very difficult to fault people for going to the wrong place because they go to someplace where they trust.
Exactly. And, they may have had themselves a past experience and not want to go to the ED, or a friend or a family member. And, there's definitely medical mistrust out there, and some of it certainly is justified. But unfortunately, then can have a bad outcome if you don't trust the ED and you needed to be in the ED, but you trust your pediatrician, and I'm grateful for that, then go to the pediatrician. But then that's why I go to the pediatricians and I say, you all have to be prepared. And I think, to your point, we have helped several pediatricians with patients who were having basically peri-arrest and did arrest in the offices. And it was like flu sepsis.
Yeah.
And boy, as common
Right.
as the flu is, how many parents check in and just say, I think they have the flu? Yep.
Right. Because it's a thing. And things are sometimes worse. Sometimes they're worse than people thought at home. And in something that's an aggressive infection, an aggressive asthma exacerbation, some of these other aggressive things, they become more aggressive before your very eyes. And being prepared is vital.
Absolutely. And one of the educational slides that I provide with we do a lot of emergency lectures, obviously, but one of them is just the curve for kids. And basically, it's a cliff. So it's not a gentle curve. It's like they're okay. And then it just literally drops off almost straight down. They're not okay. They could have been okay at home. And then they're in your office. And then that's when they fall off the cliff. And we see them do that in the ED all the time. They'll come in and they don't look that bad. And then they fall off the cliff. And it can happen for a variety of reasons. But kids, for some reason, it's like they have this amazing supply and they can withstand a lot until suddenly they just can't. That's it.
Right.
And it just depends on where they are.
And our experience with kids is that they are extremely resilient. And so, an adult who is headed the wrong direction, we kind of all expect they're going to keep going the wrong direction. But kids are remarkably resilient. And sometimes that can lull us into a false sense of security.
Yes, absolutely. I think that's one reason that parents aren't quite sure where to go because they have, to their credit, they have come to the ED a lot and we gave them Tylenol or ibuprofen and all of a sudden that's all they needed and they're running around the room and they're all great now. And that was a very expensive, timely visit for the family. And so potentially next time they'll think, oh, hey, probably just that. I'll just go see the pediatrician. And that time they weren't so lucky.
Okay. Let's map out a little bit what some of the things are that we'll talk about over the next couple of weeks. So you've touched on already the idea that everyone who works in the clinic has a role. And as a result, we should have some sort of sense of ownership of making sure that everyone understands that they have a role.
Yes, absolutely. So we do what's called crisis resource management, and that's a simulation term for team training. And it came from high reliability organizations, and you're looking at like pilots, right? And so, simulation came out of the airline industry and then went to anesthesia and luckily the ED and everywhere else because we recognize that we have specific roles, we have certain tasks, and task overload is very real. There's only so many things that one person can do at once. And that's like not just, mentally and physically, but even emotionally. Panic is real and you will lose a lot of IQ points just with panic. And I have seen a lot of people who know exactly what to do forget in a
Sure.
panic.
Sure.
When you can kind of disperse those tasks and you can have roles taken care of by multiple people, everything is a lot smoother. Things are less likely to get forgotten or dropped. You can remind each other of things. And that's one reason it's helpful that we're really trying to empower everyone to speak up. I'm teaching everybody everything because it may be that the front desk person remembers from the simulation, for example, hey, I remember that she said you had to squeeze the bag. It's not that the front desk clerk is doing your airway and breathing, but maybe they were really listening and heard that and can remind you. So it's just really important to train everybody. And you also just don't know who's going to be there when that emergency comes in because they don't time it for full staffing.
Yeah, exactly. Right. And so it's not necessarily a bad idea for our training and things like CPR to be very broad in an office.
Yes, absolutely. I think everybody in the office needs to know CPR, especially because when you start thinking of what's my skeleton crew. So as a doctor, if you're doing CPR, you really can't do anything else. And when you start thinking of all the things that need to be done, and the only thing you can do is CPR, had you trained your front desk staff, an office manager, your medical assistant, they can be doing CPR and then you can be doing everything else. You have to do CPR coaching. We even do that in the ED. You have to keep an eye on each other. You have to practice because you can't just teach people something once and then expect them to remember it in an emergency. But I do think that everyone should have CPR training and they routinely practice it. And also, really important, and I think people didn't recognize this, that you really need to teach everyone in the office where are the medical supplies and what are they. And that is like having your front desk clerk know what medications to get and where are they stored? Where is my equipment? Gathering that for you, looking through the supplies for you and getting things that you need. It's like having just extra hands, and it's just imperative during an emergency.
Which leads to point number two. We need to have those supplies, and the supplies need to be organized in a way that we can find them. They need to be updated from time to time. We'll come to this later, but one of the great suggestions you had is that teaching about the supplies, at least partly from pictures of the supplies, enables us to keep the supplies organized in a way that when I ask for this thing, they can find this thing. But if
Oh,
we
yeah.
don't have the supplies, our best training doesn't work. I can't give epinephrine if I don't have epinephrine. Sounds foolish to say, but it's a real dilemma.
Well, and even if you have the epinephrine, which all of the offices had all of the epinephrine types that they needed, but they didn't know how to give the epinephrine. And they also didn't have IV access. And then they, conceded like, okay, I haven't done an IV ever, or last time I did it was a long time ago. And if you don't know how to do an IV or are well practiced at it, you're really unlikely to get the IV on the sickest patient that you've ever seen in your clinic. You know?
Someone in respiratory collapse is very difficult to start an ideas.
Right. And I loved the pediatricians were so honest during simulations and literally would just say to the team, this kid needs an IV, but I've never done one, or I haven't done one in years, and we need to do an IO. And the fascinating thing, then what would happen is the doctor would say, I need to do an IO, and would turn to their wonderful staff and say, can you get the IO? Well, no one had ever taught any of the staff what an IO was. But the wonderful staff, always wanting to be helpful, especially in emergency, would nod, yes, I'll go get that IO. And they would disappear looking for an IO, having no idea what it was.
Right.
And they obviously would never find it. And then sometimes they would open the kit and the top thing was an IO, but they had no idea. So they would pick it up and have it sitting in their hand. The whole time they're pulling all of the equipment out. They're literally holding what they needed, but no one had instructed them what an IO was. And a lot of times the IO isn't labeled IO. It's like the Illinois bone marrow aspirator thing. Like it doesn't say IO. And so here the staff was trying to be helpful and you had the supply, but if you hadn't taught ahead of time what it was, and then, the pediatricians, I don't know how many IOs they've actually placed, but of course there was a gasp with all the staff about what an IO does. And, you
Sure.
kind of you don't want your staff to emotionally react to what you have to do in an emergency during that time. And so that's why I just say, teach everybody what is an IO, what's going to happen, what do they expect, so they can all be more helpful in emergency.
Right. Which leads to then, I think, the third big point that we'll want to emphasize, and that's that if you haven't practiced, if you haven't sort of put yourself to the test, then the likelihood of getting it right in an emergency diminishes considerably.
Oh, significantly. And I can just say that as an educator and as an educator who for decades now has been able to watch, specifically in the office, just watching a first simulation to a second simulation. So we come in, we do that first simulation. And so all of the staff with their medications and their supplies does exactly what they would have done had they had a real emergency that day. And we all saw how it went. And then we teach and we discuss and we, go through what are the medications? How should they be stored? How do we put them together? Who can be doing what? And we really work on that crisis resource management, dividing up roles, dividing up tasks, understanding what has to happen. And then it's magical. My sim team was always like, I don't know what you do, what you sprinkle in between, but it's like watching a well-oiled machine because adult learners are amazing. And they really, because they, experienced the first one, they really paid attention to the teaching. And then they would go in and run the second simulation like a well-oiled machine. And it is phenomenal to see that if we have taken the time to get organized, to prepare ourselves, to practice, that you really can save a life and do what you need to do for an emergency. And I have taught the residents this curriculum now for a couple years, and I have a pediatrician who now works in another state, and I'm still in touch with him, and he runs simulations on his group routinely and wonderfully emails me, hey, we had a real kid. We had an SVT. It came in. It went great because they've been doing all this preparation, all of the simulation. And it's so great to save a life. And you know that you did it and you did it well because you've been practicing and you were prepared.
I was going to say, I mean, the good news is once they've done that second simulation, they never need to do one again because they got it right. And
Stop while you're ahead.
exactly. We're on a roll. Let's just back out. Well, really looking forward over the next couple of weeks to getting more into the details of what we do. Dr. Spanos, thanks so much for your time and for your expertise. And for those of you who have questions, and I'm sure you do, and we'll be talking about more specific particulars as we go along, please send your questions to questions@vcurb.com. Stephanie, we'll talk next week. Is that okay?
Awesome. Looking forward to it. Thank you.
Attention pediatric healthcare professionals. Are you ready to hear the latest insights on pediatric care? Sort of like you hear on the Virtual Curbside. Join us for the 47th Annual Common Problems in Pediatrics Conference happening June 3rd and 4th, 2025, all virtual. This premier event features expert speakers and cutting-edge topics, all from the comfort of your own home or office. Earn CME and MOC2, connect with colleagues, and elevate your practice. Early bird pricing ends April 4th, so don't wait. Register now at aaputah.org events. Calling all pediatricians, family physicians, and advanced practice providers. The 47th Annual Common Problems in Pediatrics Conference is coming June 3rd and 4th, 2025. The best part, 100% virtual. Get the latest updates in pediatric care, hear from top experts, and earn CME and MOC2, all from anywhere in the world. Whether you're looking to sharpen your skills or expand your professional network, this is the event you don't want to miss. But hurry, early bird pricing ends April 4th. Register now at aaputah.org events. See you there. Thanks for joining us. We look forward to getting together again next time. The Virtual Curbside is available on iTunes or wherever you find your other favorite podcasts. Be sure to like us and subscribe. We want you to like us both because we're needy that way and because that will help other listeners like you find us. Check out our website, vcurb.com, for supporting materials, schedules, and other great stuff. The Virtual Curbside is an educational production of the Utah chapter of the American Academy of Pediatrics. The opinions expressed in this podcast, while carefully considered, are ultimately the opinions of the presenters and not necessarily of the American Academy of Pediatrics or our employers. And remember, the content of this podcast shouldn't be seen as a substitute for seeking actual personal medical care. If this is an emergency, hang up and dial 911. Otherwise, schedule a visit with a caring healthcare provider to try to get to the bottom of your concerns. None of this could happen without Elisa Stoddard, our extraordinary executive director of the Utah AAP. Many thanks to Tim Cosgrove for his help on the website and logo design. Production design, thanks to Paul Wirkus, who also composed the theme music. See you next time.